Hello, this is Diane Miller, physician and Reserve Special Agent for North Carolina Alcohol Law Enforcement. We will be talking today about the overdose prevention program within our agency. We will be discussing the opioid mechanism of action, recognizing some of the signs and symptoms of an overdose, understanding the treatment for an overdose, naloxone, otherwise known as Narcan, review how to properly administer naloxone, and then also review our ALE naloxone policy. Opioids are a class of medication that are typically used for pain management. They are traditionally derived from the opium or poppy plant, but have been chemically altered for certain forms of opioids. They have a very high abuse potential, which is very different from what we were originally told by the drug manufacturers when these medications first came out, and that led to the opioid epidemic in this country. One of the biggest concerns from a law enforcement and medical perspective is that these medications and drugs can cause respiratory depression, and as people are not breathing effectively or not breathing at all, that eventually leads to cardiac arrest and death. There's a difference between opiates and opioids. Opiates are the naturally derived opioids. These include heroin, morphine, and codeine, versus our opioids include both the natural as well as synthetic or semi-synthetic chemicals. These are constantly being changed either by the drug companies or on the street. And so traditionally you'll see oxycodone, hydrocodone, and hydromorphone are dilaudid, but now fentanyl is really one of the largest drugs that we're seeing being abused out in our country. There's also treatment with methadone, Suboxone, buprenorphine, as well as some street use of carfentanil. There are multiple variations, and these are including both pharmaceutical as well as street forms, and sometimes combinations of those. And there's different routes that they can come into the body, including being ingested, inhaled, injected, and absorbed. Opioids are chemicals that bind to receptors in the brain that help us to control pain and also can provide some reward and addictive behaviors. The benefits to this, they've been used for over the last 100 years for pain relief. We're even included in some cough medications like syrup of Vicodin. It's been used as diarrhea relief, and so you'll see that when people take large quantities of Imodium or similar products for diarrhea, if they're using it in large quantities, it's actually providing an opioid-like effect, and so you will see people abusing Imodium for that reason. And then also one of the other benefits is it can cause some euphoria and apathy. What are some of the signs and symptoms of an overdose? So you'll see pinpoint pupils. This may not always be obvious though, especially as we mix different types of medications or with alcohol. You can see some slow and ineffective breathing or even no breathing at all. You will also see altered mental status. So this is significantly drowsy, generalized weakness, or unresponsiveness. And if you are able to detect a pulse, it may be weak or thready. You also want to look at the totality of the circumstances and look for other clues. So things like track marks on the arms and legs. Don't forget to also observe in between the fingers and toes, as these may be places where people will hide some of their injection sites. You want to look around you for any pills or pill bottles, syringes and needles, powders, pipes, and other potential drug paraphernalia. So how did the opioid epidemic come about? So initially, opioids were used for short-term use for pain control, especially after surgeries. Some people, though, are having chronic pain, and so it has led to some long-term use. And due to the increased marketing of the drug companies towards the medical community, it led to a lot of overprescribing. During med school, I had a person that came in to speak to our class. He had been a lawyer and he had had an ACL surgery, and his orthopedist had prescribed him some opioid medication. What did not happen, though, is the orthopedic surgeon did not develop a plan to get his patient off of these medications. So he kept going back because he became addicted to it, kept going back to that surgeon to get more prescriptions for it. And eventually one day the surgeon said, well, I'm not going to prescribe you anymore. So he had no choice because he was not willing to admit to himself or to others that he did have a problem with addiction to opioids, that he started going to the street and buying drugs off the street. This eventually led him to losing his job, his home, his family, and he has now recovered from that through some really great programs that he was involved in, and is now going out and advocating to medical providers to be mindful of how much we're prescribing, when we're prescribing it, and making sure that we're giving plans to get people off of these drugs. So people can develop a tolerance to them, and that can cause us to have to increase doses or go to stronger types of medications like hydromorphone. People will abuse it, either using it for the wrong reason, using it to get high off of, and people also do form a physical dependence on them. There's approximately 4.3 million Americans that are using opioids for non-medical purposes in this country. I think that's probably still an underestimate. And we see at least 78 people die each day from a painkiller overdose. And we're seeing this in young people, we're seeing it in older people, we see it in all different ages. But the 21 to 35-year-old demographic is where we're seeing most of the issue with opioid use disorder. Unfortunately, we are also seeing this in the under 21 group with increasing frequency. Per the CDC, opioids are the leading cause of overdose death in the US, and over 50,000 overdose deaths were in 2021 alone. This number has increased since then. The increase in the overdoses also occurred during the peak of COVID-19 pandemic for various reasons. And the vast majority of those deaths, there was a potential to intervene, whether it was through medical providers or through family, friends, coworkers, EMS systems that are doing diversion programs. So there's a lot of different opportunities that we're missing out on to help people. So you've now interacted with a potential opioid. And so how do we keep ourselves safe during this? So we do want to practice our universal precautions. So we want to make sure that we're treating all bodily fluids and blood as if they were known to contain bloodborne pathogens. We want to make sure that we're using our proper PPE, so considering gloves, proper eye protection when interacting with patients or suspects. We want to be mindful of any contaminated sharps, especially when you're doing searches of the person or of the vehicle or other belongings. Try to use good lighting, make sure that you're turning pockets and things inside out, make sure that you're wearing good gloves. Standard nitrile gloves are sufficient protection to prevent contamination of that substance. We have had people come through and try to sell us some fentanyl-proof gloves, but we've been utilizing fentanyl in the hospital system for decades, and it is very safe for us to use our standard nitrile gloves to handle it. The biggest thing is just being mindful of your surroundings as well. So we now have an antidote for most opioid overdoses, and so this is naloxone, or Narcan is the trade name for it. This works by blocking those receptors in the brain and the nerves from and preventing the opioids from getting into those receptors. And so that way it helps to prevent any respiratory depression. It can be given by different routes. The most common that you'll see is intranasal, but you can also give it in the muscle through auto injectors, or we'll give it in the hospital through IV. The goal of naloxone, it's really important to recognize this, is to reverse respiratory depression or respiratory arrest. So that is our main goal, is when somebody has overdosed on an opioid and they are not breathing effectively or not breathing at all, we will give them naloxone for that. It is not to be used as a preventative, so before a potential exposure. This is especially important with law enforcement because if you use this on yourself or on your coworker when it is not indicated, and then the effects of that drug do kick in from the exposure, you're no longer going to have your dose of naloxone available to treat it. It should not be used on anyone if they're awake. Remember that this is specifically to reverse respiratory depression or respiratory arrest. In addition, it will not reverse death. So if somebody is in cardiac arrest, we do need to proceed with CPR and using an AED as we've been trained. So it's no longer a part of the protocol. Years ago, when we would do CPR, we would consider doing naloxone during the cardiac arrest, but it will not reverse death. And just be aware that when you do take away somebody's high, so not only is it going to reverse their respiratory depression or respiratory arrest, but it's also going to take away all the other effects of those opioids. And so they may become agitated or combative, or have other signs or symptoms of withdrawal like vomiting and diarrhea, as well as pain. So you do want to be mindful of the environment that you're in. If you are administering naloxone to somebody who is suspected of having an opioid overdose, just so that if they do become agitated or combative, they're not causing harm to themselves or to others. You do have to consider whether multiple doses of naloxone may be needed, and that's why we distribute these in 2 packs. Naloxone typically lasts about 30 to 60 minutes versus heroin can last 6 to 8 hours, methadone for 24 hours. So many of these opioids may outlast naloxone. With that said, do not administer 6, 8 doses of naloxone. If it's not working on the first couple, then there may either be a different type of ingestion or something else going on, including cardiac arrest. So we want to not waste a lot of time administering this if it's not effective and go immediately to doing CPR or rescue breaths as needed. And just make sure that if somebody does respond to the dose of naloxone, you do need to be prepared for that to wear off and the original substance to kick back in. So you may need to give an additional dose later down the road. How do we store naloxone? So if you guys are bringing in your computers to the house, or if there's an item that you're regularly bringing into your house or into the office, especially during extremes of cold and heat, you do want to bring your naloxone in with you as well. Make sure before you're using it, if it is in a clear container, that the solution is not obviously discolored. It will still work, but may not be as effective. And make sure that any replacement supplies are stored at the medical office. So if you do have somebody that resigns or retires, we do need to get their dose back so that we can account for everything, and then we will redistribute as needed. For naloxone administration, so we want to administer it when there is a suspected overdose. So going back to the totality of circumstances, we know that this is a drug user, or we see evidence of it, whether it's through track marks, pill bottles, powders, that they have pinpoint pupils, which is not a requirement, especially when there's mixed substances being used. But the most important thing, that they have slow or ineffective breathing or no breathing and altered mental status. So when you're administering the naloxone that we carry, the first step is to remove the device from the packaging. You're going to hold the device with your thumb on the plunger and 2 fingers on the nozzle. So you can see that in this photo on the bottom right. You're going to insert the tip of that into either nostril, and you're going to press on the plunger until it's completely depressed. If it does not go into their nose easily, especially if they have a deviated septum, then just switch to the other nostril. If a second dose is required, you do want to use the other nostril if possible, just so that you have maximum absorption. Some of you may have seen the Evzio auto-injector. This is a similar concept to the EpiPens or epinephrine auto-injectors. These ones came on the market probably about 10 years ago. They're very expensive, though. It's typically about $2,500 for a 2-pack. One of the advantages is that it does talk you through the whole process, but there is a needle involved, so there's always that risk of exposure from there. And again, they're very expensive. And so even if you get the dose on an initial grant program, it's unlikely that grant will be available in the future to replace it. But with the auto injector, you do want to do these on the outside of the thigh, and it can go through clothing, but just make sure that there's no cell phones or other objects in that person's pockets before you administer it. So did it work? If this works, it's going to occur within seconds to maybe a minute or two. Again, it may induce withdrawal symptoms, so vomiting, diarrhea, agitation, pain. You may need to repeat the dosing. So if the first one doesn't work right away and you still feel like it's a strong likelihood of an opioid overdose, you can give an additional dose. But if that's not working, I want you to consider doing CPR. So getting your AEDs, doing chest compressions, and if you do have a CPR mask or a bag valve mask, to do respirations as well. Remember that it may not always be effective, especially because of polysubstance ingestion. So if you have alcohol, benzodiazepines, other substances like that, it may not work to overcome those substances and only the opioid component of it. It may not be an opioid overdose at all. This could be a blood sugar emergency. It could be a head injury. It could be a heart attack. Could be a seizure. So there's a lot of other reasons why somebody may be unresponsive, even if they have a history of using opioids or other drugs. And then again, if it is a cardiac arrest, so once the heart has stopped, naloxone will not be effective. It only reverses respiratory depression. So when in doubt, again, if it is not effective or you are not sure if it is indicated, do CPR and chest compressions and use an AED if available. For rescue breaths, you want to place the person on their back. Try to do it on a firm surface in case you do need to switch to chest compressions. You want to do a head tilt chin lift, so putting the heel of one hand on their forehead and using 2 fingers to help lift up their chin. Make sure that you're pressing on the hard part of their chin, not the soft part. You can check quickly to see if there's anything in the mouth, and if there is, remove it with gloved fingers. But if don't go around fishing in there, we don't do blind finger sweeps anymore. And then with some sort of barrier device, preferably either a BVM or a face mask like shown in this picture, you can deliver 2 even breaths over 1.5 to 2 seconds, just enough for the chest to rise and fall. Make sure you're giving 1 rescue breath every 5 to 6 seconds. For canines, we do have several canine partners within our agency. They are still at risk for opioid overdose, but their risks are a little bit different from humans. Dogs are not affected by opioids in the same way humans are. I did a canine down course years ago at NC State, and they demonstrated with a 35-pound beagle and gave him 300 micrograms of fentanyl. To understand the normal dosing, so in an adult male, we would typically give 50 to 100 micrograms, and that would be significant effect on them. But this is a 35-pound dog that got at least 3 times the dose of what you would give for an average adult male. And this dog only showed a little bit of panting and drooling, but otherwise was still standing, was still awake and interactive. So dogs do not process the opioids in the same way. It takes much higher doses to have any significant effects compared to what humans would be required for a dose to have any significant effects. And that's why a lot of opioids are not used for dogs for pain control. Some of the signs and symptoms that you will see in our canine partners if they have had an exposure to opioids is drooling, nausea and vomiting or dry heaving, panting, and then eventually with really high doses, you may see some respiratory depression and some altered mental status. Canine partners are treated with the same dose of naloxone as humans. This does technically have to be prescribed by a veterinarian, but it is the exact same as what we use for humans. So how do we administer it? We're going to hold their snout closed with one hand and place the tip of the atomizer or the nasal spray device inside one nostril, press down on the plunger completely, and that will deliver the naloxone. And then be prepared to get a muzzle on them after the naloxone is administered, because just like with humans being agitated once the naloxone is administered, canines can also be unpredictable and can wake up flailing and biting. So here's an example of holding the snout closed. It's always good to approach them from behind their neck so you can get good control on them. If their handler is available, it's preferred that they are the ones that hold and administer this medication. If you ever administer naloxone, it's important to also call for EMS. Some people who have naloxone administered to them may refuse transport or evaluation by EMS, but EMS does typically have protocols on how to handle this, and so they may give an additional dose of naloxone to account for the possibility that the opioid that person overdosed on is still in their system. And then they also have several programs throughout the state where EMS will have specially trained paramedics, as well as sometimes some peers who have been through rehab before, to go out and reach out to people that have overdosed on opioids, and they can provide them some assistance with getting into buprenorphine programs or similar programs. So it's really important that if you guys do administer naloxone, that you do call for EMS as well. So what are some of the medical legal considerations? There are some rare side effects of naloxone. While it's a very safe medication, especially in somebody who is on chronic narcotics, especially people who are towards end of life, like cancer patients, you can get a phenomenon called flash pulmonary edema, where the lungs will fill up with fluid. I have not seen any cases personally of people having allergic reactions to naloxone, but really the biggest one that we're concerned about is that flash pulmonary edema. With use of force, you do need to be careful because, again, these people are going to wake up agitated. And so what has happened in the past where somebody will have an opioid overdose, they're given the maximum dose of naloxone and come out swinging, and then they then have to be sedated, or physical force for compliance and the safety of that individual and others is applied. So you do want to be really mindful, make sure you have the right resources, try to keep as calm of an environment for them, but be prepared if they do need to be subdued physically or with medications that may occur. And then what do we do if somebody refuses care after you give it to them? Definitely make sure that they have resources or know what resources are available in their community. But they do have the right to refuse if they are of sound mind and feel like they have capacity to understand their decision. But it is helpful if there's somebody that they're with, if that person can keep an eye out for them. So there is some immunity for the treatment of overdose with opioid antagonists or naloxone. So as long as somebody is doing that in good faith and exercising reasonable care, and they administer that, they are protected for multiple reasons. And so if that person does not survive, or if that person has, a bad reaction to it, it's helping to protect the person that administered the overdose. We also do have to be mindful if somebody in good faith feels like they're the only one calling for help for somebody, and that they will not be charged with that specific crime. Now, if they do have, outstanding warrants for homicide or something else. It's not going to protect them from that standpoint, but related to this specific offense, that they do have some immunity if they are providing aid in good faith. It also allows pharmacists to dispense naloxone. It's behind the counter, but not truly a prescription. So you do have to ask the pharmacist for naloxone, but they can administer it without a prescription now. It's also available in a lot of locations throughout the state through the health department, as well as the NC Harm Coalition, and in several of the county jails. And so this continues with some of the limited immunity against any violations that are occurring at the time of the overdose and administration of naloxone or requesting help for that person, but does not protect them against other major crimes. So you've given naloxone, now what? So now you need to complete the AL-69 within 24 hours. This needs to go to our overdose prevention program coordinator, Special Agent Montero. Please make sure that you do this so that we can review the use, make sure that it was appropriate, providing the education if needed, and also, most importantly, make sure that we're restocking your naloxone supply. So if you do have another encounter, you have the treatments available. Our naloxone use policy is 3.10, and so this describes all the details of our program and the goals, which are to treat opioid-related overdoses and reduce opioid-related overdose deaths. It describes our prevention program coordinator's role. We work in conjunction through the medical office with the opioid overdose coordinator. Reviews again the signs and symptoms of a potential opioid overdose, keeping in mind that there may be co-ingestions. Some of the clinical signs of exposures in our canine partners, how to use it, and then maintenance of your naloxone supplies, as well as replacement for those kits when either they expire or are used. We will be placing an order shortly and making sure that we're going out to make sure all of our supplies are up to date. Documentation requirements, again, per policy, you are required to complete the AL-69, has to be done within 24 hours. And that way we can make sure that you have a replacement. If you are one of our EMTs, we need to make sure that you're following the approved NCOEMS treatment protocols and patient care reporting requirements, in addition to doing the ALE 69. Sworn members, please remind yourselves not to self-administer naloxone or have it administered to you as precautionary or inoculation prior to an exposure. If somebody is awake, they do not need naloxone. Again, naloxone is only to treat respiratory depression or respiratory arrest in somebody who's had an exposure to an opioid. Training, we will continue to do training every year. If additional training is needed for a member or for a district, our office is more than happy to come out to do that. And here's an example of our reporting form. So we want to know your name, when did the overdose occur, what type of environment was it in, some demographics on the person, what things you noticed about them that caused you to think they were having an opioid overdose, what medications do you know or do you think they were using, and then what was their response? Did they survive or not? And then if there were any issues with the naloxone kit, either you didn't know where it was, you didn't know how to use it, or any other concerning findings, then we can address it at a program level. Once you submit this, that will trigger us to send you a new naloxone kit. Some additional resources, you can go through the CDC or SAMHSA Opioid Overdose Prevention Toolkit. And we're going to listen to a brief story. There's a lot of myths about all of these law enforcement officers that have been exposed to opioids, especially fentanyl, and they've needed naloxone, and wanted to kind of enlighten all of you a little bit on the fact that from what I have seen and others have seen, there really have been no true overdose from accidental exposures in law enforcement in this country, that there's other sources for what people are experiencing, or the naloxone is being given at an inappropriate time. So with that, we're going to pause and switch over to the recording.